Bienvenidos a este bloque en el cual vamos a trabajar en conjunto la Sociedad Latinoamericana de Nefrología junto con la Clínica Mayo. Va a ser un bloque espectacular y los que se han quedado hasta el final van a tener lo mejor. Y si se esperan un poquito y se quedan hasta el final, pues vamos a tener premio, ¿verdad? Va a haber un cóctel después para todos. Así que vale la pena que nos quedemos. Sin más ni más, vamos a comenzar presentando al doctor Fernando Fervenza, de la Clínica Mayo. Es profesor de medicina en Rochester, en Estados Unidos. Se graduó de la Universidad Pontificia Católica do Rio Grande do Sul, en Brasil. Hizo su formación en nefrología e investigación en la Universidad de Oxford y posteriormente también un fellowship en Stanford, en Estados Unidos. Es fellow de la Sociedad Americana de Nefrología, fellow del Colegio Americano de Internistas, fellow de la Sociedad Internacional de Nefrología, miembro del Board Americano de Medicina Interna, la sección Nefrología, editor secretario de Up to Date para enfermedades glomerulares, y sus áreas de interés están en perseguir la investigación orientada hacia el paciente en proyectos dedicados a avanzar el conocimiento en la patogénesis de las enfermedades glomerulares y poder proveer de nuevas formas de investigación y descubrimientos a los tratamientos a pie de cama para nuestros pacientes. Así que le damos la bienvenida al doctor Fervenza, quien nos acompaña en esta ocasión de forma remota. Adelante, doctor.
Muchas gracias. ¿Y me escuchan?
Sí, doctor, lo escuchamos perfectamente.
Bueno, y disculpe que porque me cancelaron el avión y por eso tuve que presentar, no pude estar ahí, sino era mi idea estar ahí junto con ustedes. Lo que voy a presentar a ustedes se llama Lupus Nefritis, redefiniendo los Therapeutical Goals. Y esto acá son mis financial disclosures, y los objetivos de hoy son revisar las definiciones corrientes de remisión e introducir un cambio de paradigma en el tratamiento de la nefropatía lúpica. La nefropatía lúpica es un problema para la nefrología y que está aumentando. Es asociado con una alta tasa de progresión para pacientes a ir a enfermedad renal terminal y la mortalidad a 10 años. Por ejemplo, 30% de los pacientes tienen una mortalidad de 30% y 13 pacientes van a diálisis. Y a los 10 años, 61 de esos todavía están vivos, pero no en diálisis todavía, llevando a una mortalidad estándar de 6.3, que es muy alto. Y a pesar de todos los avances que hay en los últimos años con las medicaciones que tenemos, no ha habido un improvement en la tasa de end-stage renal disease, y no ha habido una mejora en la mortalidad en las últimas 4 décadas. Y la pregunta es esta: después, a pesar de todas las nuevas medicaciones que tenemos, ¿por qué no hay esta mejora? Y yo contendo que el problema está en la definición de respuesta. La definición de respuesta de la lupus nephritis es basada en proteinuria. Es un mundo que es un proteinuric centric que se ha creado y basado en que la remisión es definida por proteinuria dependiendo de una vez si la proteinuria es menos de 0.3, 0.5, 1 grama, junto con la función renal normal y algunos de esas con una mejora de la hematuria. Pero el problema del lupus es que más que la proteinuria. Si usted mira la patología, la patogénesis del lupus, usted ve que el problema inicia acá en el sistema inmune innato que de alguna manera u otra existe, se desregula por alguna razón. Eso lleva a influenciamiento de las células T que hacen interacción con las células del sistema inmuno adquirido, esas células a través de memoria plasma, memory B cell plasma vault, resultan en la proliferación y producción de autoanticuerpos, y esos anticuerpos se reúnen con sus targets en circulación y forman esos inmunocomplex. Esos inmunocomplex se depositan en el glomérulo. El glomérulo no le gusta la deposición de inmunocomplejo y eso resulta en una proliferación, inflamación que es manifestada por hematuria, proteinuria, bajo de complemento y el tratamiento de eso, si el paciente es tratado efectivamente, el final resulta en una cicatriz que en la biopsia se llama una focal segmental. Los anticuerpos son muchos, pero les quiero convencer que el más importante que tenemos es el anti-double stranded DNA. Y que yo les quiero transmitir, para mí es un excelente biomarker de la actividad de la enfermedad, junto con los niveles de complemento. Para mostrarle que esto es verdad, les presento un paciente, una señora de 36 años, tiene una biopsia, una clase 4 y 5 lupus nefritis, que la incluimos en un tratamiento acá en la Mayo con daratumumab, Cellcept y taper dose de prednisona. Y usted ven acá en 2022, esa paciente viene con un anti-DNA que es positivo, con low complement, C3C4, proteinuria de 4 gramos y una clearance de creatinina cuantificada de 60 ml. Pacientes tratados, usted ve con daratumumab, enseguida se negativa el anti-DNA y se normaliza el complemento y eso resulta que la proteína se va abajo. Pero miren acá lo que pasa en diciembre de 2023. La paciente que era anti-DNA negative se torna anti-DNA positive. Todavía el complemento es normal, la proteína es baja, pero unos meses después la paciente no es tratada, está viajando, va a Asia para un viaje. En ese momento el complemento, la anti-DNA se va a 230, en ese momento el complemento se baja y la proteína aumenta, el paciente todavía no quiere tratamiento, vuelve más anti-DNA positive, C3, C4 bajo y más proteinuria. Mostrando que, en un sentido, lupus nephritis, que es anti-DNA positive, se comporta como los pacientes que tienen anti-PLA2R positive, miembros de Nefropatía. Usted tiene el anticuerpo si se mantiene, se sostiene por un tiempo, resulta en proteinuria, y si usted se consigue resolver el anticuerpo, la proteinuria se resuelve. Entonces, lo que les quiero proponer es que la historia de la lupus nephritis es un baile entre el fuego y el humo. El fuego representado por la actividad inmunológica, que es el anticuerpo anti-DNA y el complemento C3C4, y el humo, que es la proteinuria y el IGFR. Y el paradigma corriente es que tratemos esto, vamos a darles problema, vamos a controlar el humo. Y lo que quiero decir es que esto es el equívoco. El problema no es el humo, el problema es la actividad inmunológica. Si usted controla la actividad inmunológica, usted al final va a controlar el humo. Y en este diapositivo le muestro la idea. Tenemos una inmunológica actividad, que eso es lo que empieza. Con el tiempo eso se manifiesta en una actividad clínica, que eso es manifestada por la biopsia por una actividad histológica. Y si uno induce remisión inmunológica, eso iguala a una inducción de remisión clínica y que por señal al final va a resolver en una remisión histológica. ¿Cuál es el dado que esto es verdad? Bueno, existe un gran número de estudios que soportan el factor de que anti-double DNA está asociado con actividad de la enfermedad de lupus nephritis. Más, hay un estudio de los colegas en Italia publicado en 21 que muestra que hay un grupo de pacientes que se llama Serological Active Clinical Coagulation Disease. ¿Qué son esos? Son pacientes que están clínicamente en remisión por los conceptos de hoy, que se han vaciado en proteinuria, pero que son serológicamente activos. Quiere decir, son pacientes que tienen anti-double DNA positivo y low complement. Y este estudio es clarísimo. Si usted para la inmunosupresión en pacientes que son en remisión clínica, como la definición de hoy, pero serológicamente activo, usted ve que en estos pacientes que son clínicamente negativos y serológicamente negativos, solo 1 en 45 de esos pacientes o 2% van a tener una recidiva en la enfermedad. Pero los pacientes que están serológicamente activos, pero clínicamente, por lo que dice la cosa, 6 de 11 o 54% de los pacientes tienen una recidiva en la enfermedad. Y eso es basado, hay una cantidad de estudios que muestran que serological active, clinical active, son pacientes que van a recidivar y que uso de preemptive immunosuppression en tratamientos que son serológicamente activos previene la remisión, la reactivación de la enfermedad. Entonces, el paradigma que les propongo es que vamos a dejar de bobadas con mirar hasta el humo. Lo que tiene que ir es al fuego, la actividad inmunológica. Y les pregunto, I have so far, no he encontrado uno que me mostró, muéstreme un caso de un paciente que viene con lupus nephritis que está en prolonged complete immunological remission, que tiene anti-DNA antibody, claro que es un paciente inicialmente positivo, porque unos 20 pacientes con lupus nephritis son anti-DNA negative al empezar, pero un paciente que era positivo, que fue tratado y ahora tiene anti-DNA negative, que tiene normal complement y que permanece con negative DNA y normal complement por a prolonged time, tipo 12 a 18 meses, y que ese paciente lo biopsia y que va a mostrar que tiene una active class 3 o class 4, yo la invito a cenar en el mejor restaurante de Ecuador, porque no voy a perder esta apuesta, porque ese paciente no fue clonado. Y ahí me lleva al cuál es el papel de repetir la biopsia en pacientes de lupus nephritis. Bueno, el mejor estudio de pacientes de lupus nephritis es un estudio que el doctor Alvarado, la doctora Malvar de Buenos Aires y Brad Robin hicieron en 2014. Y para mí es el mejor estudio de todos. ¿Por qué es el mejor? Estos pacientes son 25 pacientes hispánicos, ¿no? que vinieron ahí de Bolivia a Buenos Aires a recibir la biopsia, que tuvieron 3 biopsias. La primera biopsia al diagnóstico, la segunda biopsia creo que 6 meses después, y la tercera biopsia 2 años después que esos pacientes estuvieran en remisión. Pero lo más importante es que ellos consideraron remisión los pacientes que estaban inmunológicamente negativos, SOA. Esos pacientes recibieron la biopsia 2 años después de que estaban con anti-double stranded DNA negative y tenían complemento normal. ¿Y lo que fue que encontraron? Fue que encontraron que en 56% de los pacientes, acuérdense de la actividad index de la NIH, la actividad que no tiene actividad ninguna es 0. En 56% de esos pacientes, creo que sí, o 60%, o 50%, más o menos ahí, tenían una actividad más de 0. Se ve aquí actividad de 3, 4, 1, 1, 1, 2, 2, 3, 2, etc. Mostrando que, a pesar de tener prolongada anti-double inmunología, remisión inmunológica, esos pacientes tenían actividad histológica. Pero ¿cuál es la importancia de esto? La importancia de esto es esto. Es ninguna. Porque ustedes miren acá lo que dice la función renal de sus pacientes y miren la biopsia 1. La creatinina era 122 milimoles acá y la tercera biopsia 53. O sea, mejoró. La segunda, 106, la segunda igual. La tercera, 83, la tercera biopsia 61. Mejoró. Y usted ve que todos los pacientes, con excepción de estos 2 pacientes, la función renal mejora. A pesar de que la histológica, clinical activity histology, aparece de 1 hasta 4. Los únicos 2 pacientes que pierden función renal son esos pacientes, el paciente 18 y el paciente 22. Pero mismo esto, el paciente 22, si no me equivoco, es tiene una actividad histológica de 0. Entonces, lo que este estudio muestra es el siguiente, que remisión A, y más importante, ninguno de esos pacientes tuvo recidiva de la enfermedad. No hubo un single relapse. Lo que este estudio muestra es el siguiente, que si usted tiene immunological remission, eso iguala a que va a desenvolver clinical remission. Y si y la histological activity es irrelevant, porque ninguno de los pacientes que tuvo immunological remission tuvo recidiva de la enfermedad. Entonces, eso es el mejor estudio. Por eso digo, el problema es que Brad Robin no aprendió de este estudio, porque si hubiera aprendido de este estudio, no iba a haber conseguido continuar haciendo estos otros estudios como hicieron después. Por ejemplo, este acá, en que hicieron un cohort con clase 3 y 4, completaron 12 meses de completa remisión, pero de nuevo, remisión definida por proteinuria, no por immunological remission, all right? Y esos pacientes biopsiaron y miraron la actividad de la biopsia y vieron que 30 y 30% de pacientes tenían histological activity y por eso recidivaba y decían que la repeat biopsy era de ayuda, pero ellos perdieron, como se dice, they missed the point, porque ellos no miraron cómo era la actividad inmunológica en el momento de la biopsia. El segundo punto que ese estudio muestra que es completamente relevante es porque usted ven acá que actividad de 0 o 1 o de 2 no predice si el paciente tiene un flare o no flare, porque tenían pacientes que tenían actividad de 0 y flare, de 1 y flare, y tuvo pacientes con actividad de 2 y no flare. Entonces, actividad de 1, 2 y 0 es irrelevant, porque no te ayuda. Los únicos que prevenían o predicían relapse era la actividad de 3 arriba. Pero yo de nuevo le juego una cena que ninguno de los pacientes que tenía actividad de 3, 4 y 5 tenía anti-double strand DNA normal y tenía complemento normal. Lo que pasa es que el paper no publica eso. Pero hay de nuevo una cena de que si fueran a buscar los papeles van a ver que eso. Entonces, no necesito una biopsia para decir lo que va a tener la actividad si yo sé lo que el anti-DNA me muestra y lo que tiene el C3. Y hay un otro estudio que continúa de la misma historia, de nuevo solo para mostrar, es el otro grupo, 75 pacientes de nuevo biopsiados a 12 meses, la tercera biopsia 42 meses después. De nuevo, immunological remission no fue incluida. Esos pacientes, ellos solo usan proteinuric centric, solo definen remission basada en proteinuria. Si el paciente tiene anti-double DNA positivo o negativos, no complement, es irrelevant para ellos porque son proteinuric centric. Lo importante es el mensaje del señal. Los pacientes que flare, al final, ellos tuvieron 7 pacientes que flare, all right, cuando descontinuaron de inmunosupresión. Pero ¿quién fueron los 7 pacientes? Los 7 pacientes tenían actividad índice of 0 a inmunosupresión. Entonces, muestra que la información derivada from a repeat biopsy es irrelevant, porque no puede predecir quién va a flare o quién no flare, mismo en el best case scenario, que es una actividad de 0. On the other side, yo digo que la serología puede predecir lo que la biopsia muestra. Por ejemplo, este paciente es una paciente que lo vi en 2019, el paciente venía con anti-double strand DNA very muy altísimo, más de 1000. Esa paciente tenía low complement, tenía low C4, tenía proteinuria, tenía un clearance acá de 49 ml y fue tratada con rituximab, obinutuzumab, bla, 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 bla. Vean acá que a los 3 años, de 2019 a 2022, esta paciente está en línea acá. En este momento la proteinuria de esa paciente es abajo de 200 miligramos por 24 horas. All right? Entonces, en este momento, esa paciente tiene la definición, de acuerdo con KDIGO, de acuerdo con la Rheumatology College, de que la paciente está en remisión. En remisión banana, porque si ustedes miren acá, el anti-DNA todavía está, el anti-double strand DNA todavía está elevado, que es el blue acá. el complemento todavía no va normalizado y el C4 todavía no normalizado. Si usted para inmunosupresión en este momento, ese paciente le va a explotar en la cara, porque este paciente está con una actividad inmunológica preparada. Ese paciente, 2 años después, tenía todavía anti-double strand DNA positive, a pesar que el complemento en ese momento se mejora y la clearance es 100 ml per minuto. En ese momento, yo le biopsio. ¿Y qué usted cree que la biopsia muestra? La biopsia muestra un activity index 1, a pesar de que la presión, mostrando que la activity index es irrelevant, porque recuérdese, este paciente tiene un clearance de 100 mililitros por minuto. ¿Ah? La otra historia es que, entonces, persisten de la histológica activa de un paciente con clinical immunological remission es explicado porque existe una demora del clearance de los depósitos inmunos del riñón. En una analogía al horno, si usted está haciendo un cake, pone el horno a 400 grados y después lo apaga y pone la mano 5 minutos después adentro, se va a quemar. ¿Por qué? Porque a pesar de que el fuego está desconectado, porque demora un tiempo para el problema resolverse. Y la misma cosa es la otra cosa, por cuestión de tiempo, solo mostraron un paciente de 22 años que tenía tratado en 2002, remisión completa, hace como 15 años que tiene de remisión completamente anti-double strand negative, normal complemento, no hematuria, proteína de 500 miligramos, sin ninguna inmunosupresión. En mayo del año pasado viene la proteína de 2.4. Yo le hago una biopsia, mire, se prolonga immunological remission. We do the biopsy, and what we found? A FSGS lesion. Ninguna inmunología, no inmunofluorescencia negativa, nada de proliferencia. Ese paciente fue dado lo puso con los sartán, 4 semanas después la proteinuria es a 0.4 gramos. Entonces, the target goal in lupus nephritis, la reliance en la proteinuria, que puede ser o no debido a immunological remission, no es suficiente. El concepto de induction seguido por manutención es outdated. Is induction until immunological remission is achieved. En algunos pacientes que no están en immunological remission, eso se puede trasladar en lifelong immunosuppression. ¿Cuál es el problema? No tenemos pacientes que tienen riñón de trasplantado, ninguno le pasa por la cabeza que vamos a hacer un induction therapy y después nos vamos a descontinuar. La misma cosa en la ancavasculitis. No se trata con ancavasculitis por un rituximab por 2 dosis y después no hace nada y va a mirar lo que pasa 10 años más tarde. ¿Y de dónde que sale el concepto de que el lupus le vamos a induction y después se va a mejorar? La mayor parte de pacientes es una enfermedad que, al menos, a no ser que tenemos CAR-T therapy, no hay cura. Entonces, esos pacientes hay que tratarlos y mantenerlos sin immunological remission. Y el rol de la protocol biopsy es ninguno. Porque protocol biopsy, quien entiende la enfermedad, no la usa. Y si usted entiende la enfermedad, no la usa. Y si usted no entiende la inmunológica, el concepto inmunológico, no importa que lo haga biopsia una segunda, tercera, cuarta o quinta veces, porque igual le va a hacer, no va a conseguir solucionar el problema porque usted no entiende la patología de la enfermedad. Y este concepto lo publicamos este año en Kidney International y los invito a que lo lean. Entonces, la mensaje es que there is no cure for lupus nephritis. Tal vez CAR-T puede ser. El goal de terapia no es inducir proteinuria remission, es inducir inmunológica remission. Si usted llega a esto, clínica remission va a ocurrir. Y el segundo goal de la terapia es mantener inmunológica remission. Y eso se da por evaluación de la complemento y anti-DNA crítica. Y el tercero, of course, is prevent chronic damage. Y no existe ningún rol en protocol kidney biopsy si usted sabe lo que está haciendo con el paciente. La pregunta a ustedes es: ¿cuándo es que uno va a volver a casa si el volcán está en actividad? ¿Usted biopsia la lava como hacen los que le gusta hacer protocol biopsy o usted monitora la actividad de la cratera? Yo sugiero que usted haga esta monitora antes de ir a casa en vez de eso. Y es la hora de terminar de cambiar al sistema solar ptolomeico que tiene la Tierra, el centro del universo, que es vaciada de la proteinuria, por un sistema más moderno como el Copernic System, que dice que en verdad no es la Tierra, pero sí el Sol que está en el centro del sistema solar, y eso es basado en la revolución clínica. Y no se puede reconciliar. Y proponientes como este, hechos que son baseados, como hecho el año pasado en Jason, que son baseados en las actividades de la clínica biopsia, this is not, you trash it, because this is useless. They are based on people, on failure of understanding of the lupus is immunological activity, and that is where the target of therapy should be. Finally, Max Planck, que recibió el Nobel Prize de Física en 18 por la física cuántica, el padre de la física cuántica, dijo que una verdadera verdad científica no triunfa para convencer sus oponentes y hacerlos que vean la luz, pero sí porque esos oponentes eventualmente se mueren y una nueva generación crece que es familiar con esos conceptos. Entonces, mi talk es para la nueva generación, porque para la old opponents is going to be very difficult for them to see the light. And with this, I acknowledge my collaborators, Dr. Andy Vries y Dr. Sanjeev Sethi, que va a hablar a seguir. Muchas gracias. Sanjeev. You want to present?
Just open it up.
So, Dr. Sethi va a presentar ahora.
Muy bien. Gracias, doctor Fervenza. Si hay alguna pregunta, al final hacemos las preguntas. Okay.
Okay, so you are this one. No, then you are here. Sanjeev está en mi oficina acá. So, entonces.
Doctor Fervenza, las preguntas
no,
serán
después. At the end, they will ask questions at the end, isn't it? All right, Sanjeev, you go there. Okay.
I can get started right away. Please,
yeah, vale, they want to introduce you. ¿Van a introducir al doctor Sethi?
Sí. Hello, Dr. Sethi.
Hello.
El doctor Sanjeev Sethi es un patólogo especializado en el diagnóstico de enfermedades renales. Se centra y su trabajo consiste básicamente en el resultado de enfermedades renales, gamapatía monoclonal, trastornos del complemento y enfermedades autoinmunes. Basa la clasificación de las enfermedades renales en la etiología subyacente. Está familiarizado con la identificación de las causas de la nefropatía diabética y en los protocolos de aplicación proteómica en el diagnóstico de las enfermedades renales. Adelante, doctor Sethi. Un gusto tenerlo con nosotros.
Okay. Thank you very much for having me. So today my talk is on membranous nephropathy with the special focus on the new antigens in membranous nephropathy. So I will give two examples before I start. This is example number one. This is a 55-year-old lady with history of lung cancer. She also has connective tissue disease and she has diabetes. So she has these three disease entities and she now presents with proteinuria of approximately 2 to 3 grams a day. She had a baseline proteinuria of 400 milligrams, probably from her diabetes. The serum creatinine is stable at 1.1. And a biopsy is done to determine the cause of the proteinuria. And as you can see in this biopsy, this glomerulus shows large PAS positive nodules. Further workup of immunofluorescence studies shows granular IgG along the capillary walls, and electron microscopy shows many subepithelial deposits. Taken together, the finding of thickened GBM, granular IgG along the capillary walls, and the subepithelial deposits is consistent with membranous nephropathy. In this case, as you can see over here, PLA2R studies are done, and the PLA2R studies are negative. So in other words, this is a PLA2R negative membranous nephropathy, and the question mark is what could be the possible underlying target antigen in this particular case of membranous nephropathy. Here is one more case. This is the second patient. This is a 44-year-old man with history of hypertension, now hematuria and proteinuria. He has massive proteinuria of about 20 plus grams, and he also has a history of Sjogren's syndrome with positive serologies of ANA and SSA. Serum PLA2R was negative. He has low albumin at 1.9. Creatinine is stable at 1, but keep in mind he has 20 grams of proteinuria. The biopsy again shows a membranous nephropathy. For shortage of time, I'm not showing immunofluorescence studies, but you can see the interstitium is well preserved. The glomeruli look sort of normal on light microscopy, but on electron microscopy, clearly you can see numerous subepithelial deposits along the capillary walls. So this is another case of membranous nephropathy, and in this particular case, also PLA2R studies were negative. So this is a membranous nephropathy that is also PLA2R negative, but in the setting of Sjogren's syndrome. So what is membranous nephropathy? It is the most common cause of nephrotic syndrome in the adult white patients. The incidence tends to increase, and by the time you come to the age of 60 is where it peaks. 2-to-1 male predominance, somewhat rare in children. Again, mostly in whites, Asians, blacks, Hispanics, all of them get it in this order. Incidence is about 10 to 20 per million per year, so close to about 3,000 to 4,000 new cases in the US per year. At the Mayo Clinic, we get between 500 to 700 kidney biopsies a year of just membranous nephropathy. The biopsy findings of membranous nephropathy are very typical. They show thickened glomerular basement membranes, almost no inflammatory cells in the capillary loop, so it's not an inflammatory process, but you can see extremely thickened GBM. The take-home or the most classic finding is the finding of IgG, granular IgG that lines the capillary walls, and this IgG is forming immune complexes with an underlying antigen, and this is shown in the electron microscopy that shows large subepithelial electron-dense deposits. The location of subepithelial versus subendothelial is the reason why there is no inflammation in membranous nephropathy, because these are all subepithelial, and the GBM sort of protects these deposits from neutrophils and monocytes. You can see over here in between the deposits, you can sometimes get basement membrane material, and this is what is called spikes, and you can see the spikes nicely on the silver stain over here. And the spikes just represent GBM remodeling. So this is a picture of membranous nephropathy. The most important thing to remember is the granular IgG along the capillary walls targeting some antigen and forming these large subepithelial electron-dense deposits. Okay, so for the longest time, membranous nephropathy was classified into two, primary and secondary. Primary is when there was no disease association, and secondary are these various things listed in red, autoimmune disease, like that patient I just showed you with Sjogren's syndrome, then infectious diseases, syphilis and hepatitis, and sometimes schistosoma, malaria. Drugs are an important cause, including NSAIDs and heavy metals. And then there's a long miscellaneous list that includes tumors and stem cell transplant and antibody-mediated rejection. Okay, so the target antigen for like I told you, that the immune deposits are consistent of IgG targeting an antigen remained elusive for a very long time, and we were making the classification of primary and secondary. But then in 2009, everything changed with the discovery of PLA2R, which is the target antigen in most cases of primary membranous nephropathy, this particular group. And subsequently, a second target antigen was also discovered. This is thrombospondin 7A by pretty much the same group from Boston and from France. This is Larry Beck and David Salant who discovered PLA2R, and then subsequently this came out of Europe, Germany and France and the US as well. And so this was thrombospondin 7A. Thrombospondin 7A is really rare. We only get 3-4 cases per year. But PLA2R, as you know, changed everything. And this accounts for close to 70 to 75% of the membranous nephropathy in the primary group. Keep that in mind. And so here you have, this is PLA2R staining. Almost all labs do PLA2R staining now. And at this time, we were classifying membranous nephropathy based on PLA2R staining, positive versus negative. So this is what membranous nephropathy really looked like. Here's membranous nephropathy, primary 70%. 70% of them are PLA2R positive, 1 to 5% thrombospondin 7A positive, and 30% of primary, we do not know what the antigen is. And in the secondary group, almost all the causes, we had no idea what the target antigen was, except thrombospondin 7A was positive in a few cases associated with tumors. Okay, so we call this the big PLA2R negative antigen group. So what we decided to do is, in order to find these particular antigens, we said we could probably do, this was just really a trial, that we could dissect the glomeruli. Over here, for example, this is dissecting the glomeruli. This is following the dissection, it's empty space. After you dissect the glomeruli, you can do a little trypsin digestion of the material. You can separate these proteins and amino acids on an HPLC column, and then you label the amino acids and the small peptides with an ionization spray, and then the amino acids are then detected by mass spectrometry, and you get the various proteins that are present in this particular microdissected glomerulus, and then you analyze the data. Just to show you, for example, this is a glomerulus that is dissected, and what we decided to do in the beginning is to look for PLA2R. So these are 7, each column is one case over here, and as you can see, it was relatively easy to find PLA2R in all the PLA2R positive cases. Okay, this is 7 cases of PLA2R. The simple basic immunology is that one IgG targets one antigen. So if there is a lot of IgG along the capillary walls, a lot of immune deposits, there should certainly be a lot of antigen in there as well. So that's why it was quite easy to find PLA2R. In the next step, what we did was we decided to take PLA2R negative membranous nephropathy, like those 2 cases that I showed you, and let's do mass spectrometry. So what we found after laser microdissection was 5 of the first 15 cases we did found a novel protein called exostosin 1 and exostosin 2. You can see here. This is a readout, but most of the proteins you can see have spectral counts that are very low. And occasionally you see a high spectral count. I don't think you can see this. This is 66, but this is complement. So the most important protein that we found was exostosin 1 and 2. And then the next step was to do more and more cases. And as I did more and more cases, we found many cases of exostosin. Each column is one case. And these are 25 cases showing you the exostosin. And this is the IgG profile. And I don't have time to go into it, but you can also look at the IgG subtypes in each particular case. And then the next step, of course, is to do the staining. When we did the staining for exostosin, it was beautiful granular staining along the glomerular capillary walls, just like the IgG staining along the capillary walls in membranous nephropathy. So we felt at that time that exostosin 1 and exostosin 2 were new novel antigens in membranous nephropathy. Furthermore, when we looked at the clinical details of these 25, 26 cases, we found most of these patients were female, 80%. They were young, 35 years, and almost all patients had serology that was compatible with autoimmune disease. At that time, we were not looking for specifically for lupus, but about 35% of our patients ended up having lupus. And so we found that exostosin 1 and 2 was present in membranous nephropathy in patients with an autoimmune disease. So conclusion number 1 is this was the first antigen that we found that exostosin 1 and 2 is in the setting of autoimmune disease and most likely represents a target antigen in secondary membranous nephropathy associated with autoimmune disease. Going further, we've continued to do more and more mass spectrometry of PLA2R negative cases. And another protein that was very regularly appearing was what's called NEL1. And you can see here 20 or 30 cases of NEL1 with very high spectral counts. And I won't go into this part. And of course, we did the immunohistochemistry for NEL1, and you could see that NEL1 was staining very beautifully along the capillary wall. So it was just like you expected membranous nephropathy. Few cases were also showing segmental staining. Next step, of course, is do confocal microscopy to make sure that the NEL1 and the IgG sort of co-localize. So this is NEL1 antigen. staining, and this is the IgG staining. And when you put the IgG on the NEL1, it becomes yellow. And so you know they are sort of co-localizing. This is a high power showing you the same thing of just a few loops. While in exostosin, we were not able to find the circulating antibody. In this particular case, we luckily had some serum samples that were available, and you could find that in these patients, we could, using Western blot analysis, we could find that these patients had circulating anti-NEL1 antibodies. This particular patient is one patient, and this patient was treated with immunosuppressives. And as the patient went into remission, the antibody showed that it was also disappearing. So it fit very nicely. So NEL1 was the second antigen that was detected from our group, and it was in about 10% of the cases, and there is segmental staining in a subset of these patients. NEL1 turns out to be the most heterogeneous of all membranous nephropathy antigens. You can see it in a large number of cases that are primary, but you can also see it in patients who have tumors, in the setting of autoimmune disease, sarcoidosis, transplant, stem cell transplant, and the big one is drugs. Patients who use certain creams that are loaded with mercury or herbal medications that are loaded with mercury. Many of these patients with sort of indigenous drugs that are tainted often will have NEL1 associated membranous nephropathy. Okay, and many of these patients may have heavy metals that are particularly mercury that might be a constituent of these drugs. So that was the second one. And NEL1 turns out to be the second most common antigen in membranous nephropathy. And you can see it both in the setting of primary and various secondary causes. The third antigen that we found as we continued to do more and more mass spectrometry of PLA2R negative cases was a protein called semaphorin. I won't go into detail here, just to give you a rough idea. Semaphorin is very unique in that it occurs in patients who are very young. Many of these are less than 2 years of age. It's extremely progressive. Most of these patients, if not treated, will go to end-stage disease. And when they are transplanted, semaphorin will recur in the transplanted kidney. Now we have seen quite a few of semaphorin cases in the pediatric age group. In fact, every time we get a few pediatric cases, we are seeing more and more semaphorin 3B. One more antigen that I want to mention is something called protocadarin 7. This is the opposite of semaphorin. This occurs in older patients versus the younger patients. These patients tend to have a good prognosis, and many of these patients will have spontaneous remission with conservative management. So this is opposite of semaphorin. Semaphorin is progressive, and they don't do so well. And in pediatric, this is older patients with good outcomes. Couple very specific proteins that we found as antigens. As you know, patients who have stem cell transplant can develop membranous nephropathy. The most common cause of nephrotic syndrome in patients with stem cell transplant is membranous nephropathy. The antigen in these patients is not known. It's not PLA2R. And this is the new antigen that we found. Almost 100% patients of stem cell transplant-associated membranous nephropathy have FAT1. We have also recently found that FAT1 is also present in patients who have antibody-mediated rejection. Okay, and this is the second last one. This is NDNF, patients with syphilis. Now, syphilis is an endemic disease. There are 5 million new cases of syphilis every year. The number one cause of proteinuria in patients with syphilis is membranous nephropathy, and the antigen of syphilis is NDNF. Okay. And lastly, PCSK6. Patients who take NSAIDs can also develop membranous nephropathy. The antigen in these cases was not known, and what we were able to show that many of these patients have an antigen called PCSK6, which is the target antigen in patients taking NSAIDs. Okay, so what are the antigens telling us? It is not a matter of just, okay, they don't mean anything. Each antigen has a story to tell. So for example, exostosin, autoimmune disease, NEL1, very heterogeneous and ubiquitous, keep that in mind. Protocadarin 7, older patients, good outcomes. Semaphorin, pediatric, can recur. NCAM1, I didn't go through it, was autoimmune disease. FAT1, stem cell transplant. Contactin 1, I didn't go through this. This is demyelinating polyneuropathies. NDNF is syphilis. PCSK6 is NSAIDs. So each one of them is telling you a story. These are two extremely rare antigens, less than 1%, that were also recently described. Okay, so what happened to those two cases that I showed you? Patient number 1 had diabetes, had a connective tissue disorder, and had cancer. What was the cause in this particular patient? We found exostocin. So in this particular patient, it was most likely the connective tissue disorder that was causing the membranous nephropathy. What about the second case? The patient had Sjogren's syndrome. In this case, we found that the patient was taking NSAIDs, and it was truly due to the NSAIDs and not due to the Sjogren's syndrome, because we found PCSK6. So clearly, by just looking at those two cases, we can figure out what the underlying etiology was of the membranous nephropathy. And oops, I hit something. Okay, the last few summary slides. So what was the black box now is filled up. Before, we only knew primary membranous nephropathy, PLA2 or thrombus 1 and 7A. But now if you look at the entire chart, we can almost tell the antigen in almost all of these causes of membranous nephropathy. So the final summary is, it's extremely important that we type membranous nephropathy based on the target antigen. Many of these target antigens have specific clinical and pathologic features. Most importantly, serologic testing of antibody needs to become available. From what I know, NEL1 antibody serology test is going to be available very soon. And I have many people to thank. These are the people who do the mass spectrometry. Of course, you know Fernando, he just spoke. And these are the people who do the immunohistochemistry. And there are many people here in various labs who did various parts of the studies. So I will stop here exactly at 19 minutes. I was allowed 20 minutes, so thank you very much.
Go here, I can sit here.
Exactly 20 minutes.
Fantastic. Thank you.
Thank you very much. We will beg you to stay for some minutes because we still have a couple of local lectures from your colleagues. But then we will have the block for the questions. So if you don't mind to wait a little bit.
No, I have to go.
Gracias.
Mire que Sanjeev tiene que irse. Si quiere hacer pregunta, hágala ahora.
Muy bien. Entonces les comentaba que si pueden esperar unos minutos porque tenemos 2 presentaciones más en persona ahora acá en el salón, continuando con nuestro bloque de colaboración con la Clínica Mayo. Y Sanjeev no puede exactamente. Entonces, si hubiera alguna pregunta en este momento para Sanjeev, podemos aprovechar y hacérsela, por favor.
Yeah, but how can I have to go with you because I don't have a car?
Or I bring your car and you come back.
Doctor Fervenza, si tiene buen audio y nos puede, si usted escucha al público, nos lo confirma y si no, yo repito lo que estemos escuchando acá en el salón.
Yo le escucho a usted, pero no escucho al público. No sé si el público habla alguna cosa.
En este momento hacemos una pregunta, probamos. Por favor, adelante.
Buenas tardes. Una duda, ¿qué hacer con aquellos pacientes que están inmunológicamente activos, pero tienen clínicamente una remisión prolongada? Es decir, ya no tienen hematuria, no tienen proteinuria, tienen el complemento normal, pero el anti-DNA sigue siendo positivo.
Bueno, de nuevo, hay que la terapia es individualizar. Siempre hay que ver qué paciente es. Si el paciente tiene función renal normal, es una paciente joven, tiene función renal normal y tiene un anti-DNA que es positivo, pero los complementos se normalizaron, mi recomendación en el paciente es que usted lo mantenga en maintenance immunosuppression. Si usted lo usa, si usted lo usa mycophenolic mofetil long term, tan lejos de so long as the patient tenga anti-double DNA positivo, yo lo mantengo en maintenance immunosuppression. Si el paciente por alguna manera quiere parar la inmunosupresión, Bueno, es un riesgo que toma, pero hay que avisarla que ese paciente, lo mínimo es cada 3 meses hacerle una urinálisis, hacerle de nuevo el DNA, hacerle el complemento, porque como mostré allá, si ese paciente está con DNA positivo y usted lo para la inmunosupresión, pero 3 meses después el complemento se baja para abajo, ojo, porque ese paciente que está como el que le mostré ahí va a relapsar. Y ese es el problema.
Gracias. Tomamos una pregunta más, por favor.
¿La puedo hacer en inglés y después la traduzco? O sea,
Oh,
en
está
español.
bien en español. El doctor Fervenza
Sí.
nos ayuda
No,
en español.
bueno, como que mi pregunta es la siguiente, para los dos en realidad. Yo trabajo en Estados Unidos, tengo la posibilidad de mandar la sangre de mis pacientes con nefropatía de membranosa a Mayo Clinic, donde hacen lo que se llama un membranosa cascade, ¿no? Que chequean para PLHR, si es negativo, van pasando por los diferentes antígenos. Yo recibo ese resultado negativo, por ejemplo, la pregunta que yo tengo es ¿qué probabilidad hay que al tener un negative membranous cascade haya un antígeno en la biopsia, en el tejido, que haya que ir a buscar al tejido, como pasa con el PLHR, que no está siempre positivo en la sangre?
Yeah, she's asking, answer. She's asking that the patient that the cascade is in the mass spectrometry.
So,
Okay?
I can tell. So, you are asking if the patient is PLA2R negative, what to do next? How to?
No, my question in English is, Doc, I can do it in English.
For all antigens.
Okay, so about 10 to 20% of the cases when we do mass spectrometry also we don't have an answer. The question is there are a few antigens that are rare that over the next few years either me or somebody else will describe them. They have not yet been described. When you do mass spectrometry on these PLA2R negative cases and you don't find any of the known antigens that are already published, I can tell you when I look at the studies, I know there's a few antigens over there, but these have not yet been described.
No, but my question is actually, if I have a negative blood test for all these antigens, what is the chance I'm missing the antigen in the tissue?
But it's not available, Laura. The only blood test that we have now is for PLA2R and thrombospondin. The one that is coming is NEL1, but it still is the Euroimmune promises that is going to be available, but is not. What Mayo does, we do is the mass spectrometer of the tissue. We don't do in the serum where we have these two. But what we have found is, in fact, a patient from Argentina that I just saw, and I have been looking for that, is a patient that was, it's a patient of Dr. Mascaroni, who was in the audience, all right, that was diagnosed in 2022 in Buenos Aires, who had massive proteinuria, 10 grams, and was PLA2R repeatedly negative, several times, and he was rebiopsied in 2025. The patient came here last month. We did Sanjeev did mass spectrometry on that thing. We repeated, we did here we do check for PLA2R by Euroimmune. We did immunofluorescence, and we did a new Euroimmune clear, and all those things were negative. But the mass spectrometry showed PLA2R spectral count of 140, which is very high. So this is we don't know how to explain this, but this is a positive mass spectrometry, but serology negative.
Okay, exactly. Thank you.
Muchas gracias al doctor Sanjeev Sethi y al doctor Fervenza por sus participaciones, haber solventado las dificultades de último minuto en sus vuelos. Vamos a continuar con el bloque y a continuación vamos a presentar al doctor Filippo Pinto. Él es geneticista clínico, director médico del programa de enfermedades raras en la Clínica Mayo. Él nos hablará sobre la medicina genómica en la consulta de la nefrología. En su práctica clínica, el doctor trabaja con exoma, genoma y transcriptoma para tratar de ayudar a establecer el diagnóstico en pacientes con enfermedades difíciles. Doctor Filippo, por favor.
Good afternoon. First of all, I can understand Spanish, but my Spanish is worse than this English, so I'm going to talk in English. But if you have any questions, we can for sure discuss in Spanish, Portuguese, or English. Thank you very much for inviting me. It's a pleasure to be in a room with so many colleagues from nephrology. And let me start my slides here. I said that I have nothing to disclose, but my most important disclosure is that I'm not a nephrologist. So I like you guys, I like the kidney, but bear with me. If I say anything that's wrong, know that I'm a clinical geneticist who is only here to help you out with some genetic testing. My talk today, I just want to briefly touch on why we do genetic testing, and then spending a little bit of time explaining the types of genetic testing that we can do in all the clinics, especially in nephrology. Talk a little bit about variant interpretation. I know that's a big deal when you get genetic testing results, when we don't know what to do with those results. And then I'm going to share a couple of cases that are interesting, and so you can see if you have similar cases in your clinic, and then we can discuss later if you have any questions. So why we do genetic testing? Many times it's just to diagnose a patient, right? And when I say just, it's because it's cool. We say that, oh, now I have a name for your disease. But actually, the type of genetic testing that we do and the type of results that we get can impact the treatment for our patients. So for example, for collagen 4A Alport syndrome, knowing that a patient has a missense variant in comparison to other types of variants, we know that the patient probably is going to progress in a milder fashion than if a patient has a more severe type of variant. And if we have a patient with focal segmental glomerulosclerosis and we diagnose this patient with a genetic cause, we don't need to use immunosuppressants because that patient probably, or most likely doesn't have a primary FSGS. So the treatment is different. So that's why we would do genetic testing for patients with focal segmental glomerulosclerosis. For Fabry disease, it's a rare condition, but if we do genetic testing and we find the type of variant that is amenable to chaperones, we don't need to put this patient in enzyme replacement therapy. We can use a pill, and this patient could do well depending on the type of disease that we are dealing with here. And you've heard through in this couple of days about primary hyperoxaluria type 1. So doing genetic testing, even though you did biochemical and you find that the patient has a pH, knowing that this patient has a pH 1 could help us in prescribing some specific drugs for that condition. So genetic testing, even if you have a biochemical diagnosis, could be important for this patient. I swear that this is the only slide that I'm going to talk about genetics here, so we can go back to our early years in med school. But I feel that this is important because many times we forget how genetic testing works and what a gene is. So you can see this is a big picture of a gene, and you see that in green we have the exons, in pink we have the introns, and then everything else, right? When we do a target panel, the labs are only looking at those green parts and a little bit of the pink parts, but mostly the green parts. When we do exome sequencing, which we think that it's way better than target panels, actually we are looking at exactly the same places, but we are looking at more genes, but we are still looking only at those green bars. There are some exome sequencing that they include other parts, but still, even though we sequence other parts of the gene or the exons, the analysis focuses only on the green part. Now, we can do genome sequencing in the clinic, right? And now we can sequence everything, not only the green and the pink parts, but we can see everything that's there. The problem with this is our analysis is still focused only on those regions that the target panel are focused on. So when someone says, let's do genome sequencing because it's better because our panel is negative, just be careful. It's not because you do a fancier test that you're going to find an answer. Maybe the answer is there and the lab didn't analyze because the analysis is focused on the same parts, okay? There are many publications comparing what's best, target panels, exomes, or genome sequencing, and I just want to show you that there are some publications showing that exome sequencing has a diagnostic yield of lower than 10%, and some very minimal target panels have a diagnostic yield of over 50 or 60%. Why is that? Because panels are better than exome, or because exomes are not as good as we thought? No, it's because it all depends on the phenotype that we are testing. So usually people would do exome sequencing for more complex phenotypes and target panels when you know what you're looking for. So if you have a patient with kidney cysts, you know that you have to focus on PKD1, PKD2, and some other genes, right? So that's fine to do a target panel. Exome sequencing is not going to be better than that. So be aware of this. When people say that, oh, exome or genome are way better because you can sequence more, might not be true. What we know is, depending on the phenotype, so for pediatric cases, for cystic disease, or if you have a family history, positive family history, those are the phenotypes that would yield a higher diagnostics for genetic testing, regardless of the genetic testing technology that you're using. So here at Mayo, we created what we call the Nephrology Genomic Clinic, meaning that for every patient, we do genetic testing. As soon as we receive the genetic testing results, we sit together with nephrologists, geneticists, researchers, you name it. Everybody who's interested in doing genetic testing for these patients, we discuss these results together, and then we come up with a plan. And then we have genetic counselors. I'm not sure in Ecuador or in other countries here in Latin America you have genetic counselors, but in US we do. But for example, in Brazil we don't, so it's based on the geneticists to do the whole counseling session. In any ways, what I want to point out is that we need a multidisciplinary team to deal with genetic testing results. It's not as easy as it seems like, because a lab is doing at no cost some genetic testing. We always need to discuss these results, and I'm going to show you a couple of cases why this is important. So these were our first results. I don't expect you to read about all those, but at the beginning, when we were discussing these cases, we had a diagnostic yield of 30% across all the phenotypes. And as I said before, this is misleading, so the number 30% doesn't mean a lot when you start discussing like specific phenotypes. You can see there are some phenotypes that we have a diagnostic yield of over 60%. So for tubular interstitial disease, we have as high as 60%. For stones, for example, I think we have around 25-ish. Yes, 25%. And then for other types of diseases, we have 15. So it's not a matter of giving you a number as 30, right? It all depends on the type of phenotype that we're testing. I'm bringing one example here. It's this very targeted FSGS clinic with Dr. Fervenza, for example. So we tested 49 patients at a time, okay? And then you can see how we classify the proteinuria and the food process effacement here. But what I wanted to point out is, for patients who had an FSGS lesion in the kidney biopsy, for when they had an undetermined FSGS, or when they have a secondary FSGS that the nephrologist didn't know the cause, we had a genetic cause for those patients in over 70% of those cases, 71%. More important than that is for cases that the nephrologist was very certain that they knew what was causing the FSGS, let's say obesity, sleep apnea, or you know better than anyone. Even for those cases that we did have an answer, or we thought we did, in 30% of those cases, they actually had a genetic cause for those phenotypes. And probably we would never test those because we already diagnosed those patients in the clinic, right? So that was what opened up the gates for doing more genetic testing in our clinic. So if we have a patient with focal segmental glomerulosclerosis, we do genetic testing. Regardless of the type, we can discuss target, exome, or genome, but we should do genetic tests for those patients. So I'm going to bring you a couple of cases. This is a patient with kidney stones from Dr. Liski, 45-year-old with recurrent kidney stones. We were, at the time that we would like to do exome sequencing for everybody, we did exome sequencing for this patient, and we found a single variant in a recessive gene. So if we know a little bit about genetics, when we deal with recessive conditions, we need 2 variants. So a single variant, in theory, shouldn't be the cause for a recessive condition. What happened here is, because we discussed in a multidisciplinary team, we knew the limitations of exome sequencing, and we're going to talk in a moment here, we suggested to do a more in-depth analysis using a target panel. So going back to a target panel. And when we did the target panel, we found that this patient actually had a deletion that was missed by exome sequencing. So using target panel was better for this patient because we had a higher depth, we had a higher coverage for those genes, and we could find a deletion that exome sequencing miss. So what exome miss? So some proteins, coding genes we miss still depending on the type of these genes. Of course, because we're focusing on the coding part of the genome, we are missing everything else. So we are only looking at those green bars. Everything else is missed because we are not even checked those. There are some structural changes. So copy number changes. So these deletions and duplications, when they are small, exome sequencing does not perform well. And regardless of the lab, it's not the lab's fault. It's because the technology is not good enough to find these small deletions. And that's what happened in this case. I just want to show you what our colleagues in the lab, they see in the data. When we say that, oh, let's check the genomic raw data. So this is what they see behind the scenes in the computers. So you can see this is PKD1, a gene that's very important for kidney cysts, as everybody knows. Those blue bars on the bottom are the exons, are the green parts that we were talking about. And you can see that there are some reads in some of those exons, but there are many of those exons that have no coverage at all. So if you are checking for PKD1 variants in a patient and you're doing exome sequencing, you probably are missing many of the regions that could have a variant there. So why we would do genomes? Because now we are having uniform coverage. We have coverage for every single part, including introns and other parts, right? Because of that, we can call deletions and duplications in a better way than exomes, and we can find bigger structure variants like translocations and things like this. Here is a PKD1 genome. So I think it's clear that now if you have a patient with PKD1, still genome is not perfect. There are some caveats doing genomes, but you can see in the comparison with the previous slide that we have way better coverage when doing genomes for PKD1. And this was helpful for one of our patients, and you can see here, I think it's clear that there is a deletion there that would be missed by exomes and was missed by target panels as well, because it's a deletion encompassing the first exon, and there are some problems analyzing first exons of those genes. I'm just telling you that anytime that you have a negative genetic testing and you feel that this patient has a genetic condition, think about the limitations of the genetic testing that you're doing, okay? Another case, and apparently genome sequencing is the best, right? So I'm just bringing this case so we can discuss a little bit more. So this patient from Dr. Fervenza, 28-year-old with proteinuria, focal segmental glomerulosclerosis, everybody thought that this patient had Alport, okay? Someone did the staining for collagen 4A5. The staining was normal. So again, we have to keep this in mind. It's not perfect staining for collagen. We usually miss some patients. But this was negative. So the nephrologist outside Mayo thought that this was not Alport because the staining was normal. So family history was really strong for an X-linked condition. Many great uncles, many cousins with a similar phenotype. With Alport's or Bright's disease. So someone did a target panel, they found nothing. Dr. Fervenza actually referred this patient to us asking for exome, because at that time exome was the best that we could do. And then we reviewed this phenotype of the family history, and we suggest that instead of doing exome, like testing for more genes wouldn't help us, because we still think that it would be collagen 4A5. So we should check for the regions that the target panel had missed. Right? So let's do a genome-based panel. And we did, and I was pretty certain that we would find an answer, and actually the test was negative. And then people start doubting about genetics and geneticists because, come on, we did genomes, right? We could not miss with genome. What happened here was that actually, I think we are missing a slide here, but what happened here was that a variant was intronic, and the lab didn't analyze the variant. So they sequenced everything, but because the variant was intronic, they didn't report. So once we went back to the data, we checked the intronic regions, and this patient indeed had intronic variant in collagen 4A5. We checked the same variant in other family members, and we proved that this was like it was segregating with disease, and then we found an answer for this patient. Okay, so genome sequencing is great if you know the limitations of the analysis as well. So talking about analysis, right? Variant interpretation. I don't have time to go over all the variant interpretation criteria, but I want to point out some things. Everybody hears about the 2015 guidelines, how we analyze variants, how we interpreted variants, right? The way that the labs analyze variants, they combine many levels of evidence. So they check if the variant has been seen in an affected individual, if a variant has been seen in the general population, if we have functional evidence about this variant. So they put together as a puzzle, and then they give us a name for that variant. And this could be likely pathogenic, and most of the times it's going to be a variant of uncertain significance, because at that time we don't have enough evidence to reclassify the variant, okay? And we follow these guidelines, but what I want to point out is this is called the 2015, but we've had, for every single criteria, we have had already a new updated way of looking at this data. So if a lab is saying that they are classifying a variant using ACMG guidelines, you have to be aware if they are actually updating their criteria. And this changes completely the way that we interpret the variants. More important for us here is that there is these general guidelines, but there are groups focusing on developing specific gene-specific guidelines. So for example, there are for many other groups, but for nephrology, there are two groups focusing on Alport and kidney cysts. So soon we will have specific guidelines so we know how to interpret variants in those genes. So how can we do anything in the clinic to try to answer some questions, right? Of course, it's great to be in the big company, big institutions that you can do functional validation, you can do animal models and things like this. I can tell you that even at Mayo, we don't do this for every patient, right? It's just impossible. So us in the clinic, how can we help our colleagues in the lab? So this is the table that I showed you that they use. So you can see that the first row is based on population data. The second row is computational, functional, and so on and so forth. So all these squares here, we as clinicians, we can help the lab to reclassify a variant. And not only we can help because we can find some information, but we can actually elevate this level of evidence if we can do more on the clinical side. And when I say that is, if you can go back to family members and segregate this variant, check for phenotypes that we might have missed, and this happened many times. I'm going to show you in a moment here. Test parents. Anytime that's possible, please test the parents. I know that's hard for adults, but if possible, not only parents, but if you can find some relatives that would be in the family pedigree that could be informative, please try to test them, because knowing that a variant is de novo, meaning that appeared only in the proband, it could help the lab in reclassifying the variant. If it's inherited from someone who has a milder disease, for example, it happens many times in Alport, yes, the lab can use this information to reclassify the variant as well. So this is one example. So we found a VUS in collagen 4A3 for a patient, and you can see here, I don't think you can see here, but okay, this patient was positive for the variant. The patient had FSGS. We asked about family history, and he denied. No one has ever talked about FSGS or Alport in his family. But then we went back and found out that a couple of other relatives, they did have hematuria. Sometimes people just don't care. They don't talk about hematuria to other family members, right? So keep this in mind that we might be missing phenotypes that are relevant for us that specific proband didn't talk about. So that's what we found out talking to these family members, that a couple of them, they had hematuria. We were able to test those patients. They were positive for that specific variant, and because of that, the lab was able to reclassify this variant from VUS to a likely pathogenic variant. So I just want to finish here with some remarks. Next generation sequencing has great potential in nephrology, as I hope you see this. But the type of genomic testing, it all depends on the accessibility that we have. It's based on the country that we are, the costs that implies in each of those technologies. There is no one single test that's perfect, so we can always discuss what would be best for that family. It all depends on the phenotype that we're testing, and most important is that variant interpretation is science. All these results are dynamic. Something that I call VUS today, tomorrow we can reclassify that based on more information. So with that, I want to acknowledge all this group, and I'm happy to take any questions.
A continuación, el doctor Naim Issa nos va a presentar el tema de donación de trasplante de riñón de donante vivo. Él es nefrólogo de trasplante en la Clínica Mayo, jefe de la División de Nefrología e Hipertensión de la Mayo Clinic, profesor asociado de la Escuela de Medicina de la Clínica Mayo, y sus áreas de interés incluyen trasplante renopancreático y trasplante de donante vivo. Así que, doctor, adelante, por favor. Las preguntas al final de la presentación.
Muchas gracias por la invitación. Thank you so much. On behalf of myself, my colleagues from the Mayo Clinic, I really thank you for the great hospitality and inviting us. When I was tasked to talk about kidney transplantation, for a group, I looked actually at the rates of living kidney donation in South America, and I was kind of surprised they're very low, not in par with other parts of the world, where about 40% of kidney transplantation is done from living kidney donors. I saw in Ecuador about 10% or less, in Brazil about 15%, in Argentina about 15% or less. I know those are governed by many laws and by cultural beliefs, and I hope, share with you our experience with more complex donors that we see in the clinic. Okay. How do I advance? Oh, sorry. So what we will do, I'll try to be cognizant of the time. I know we're really behind. We'll talk about the available evidence and the emerging challenges in living kidney donation. Mostly we'll talk about if those patients who donate a kidney face higher mortality or cardiovascular disease compared to non-donors. We'll talk about if there is any end-stage kidney disease risk that they're taking, and we'll talk about very specific types of donors that we see more and more in the clinic, such as overweight or obese donor outcomes, hypertensive donors outcomes, and pregnancy risk and other emerging medical issues. I'll share with you a lot of work that has been done in our transplant center. Why living kidney donation? Because we know it actually confers the highest life expectancy, as you can see here, and there are so many studies around that. If you have, for example, a patient who's facing dialysis versus getting kidney transplant, their mortality is very high on dialysis, and this is across all age group, even in older patients, 65 plus, they still benefit from kidney transplant. When it's done from a living donor, as you can see, there is actually a large survival benefit when compared to deceased donor kidney transplant. So why we're concerned about living kidney donation? So you ask yourself what happens to a living kidney donor. Of course, it's no secret. You remove one kidney, you lose 50% of the kidney mass. On the spot, you lose about 50% if both kidneys contributing to total kidney function by 50%, you lose a GFR of 50%. While the good news that actually loss of GFR is less over time. The other kidney will accommodate, will compensate for the work of two kidneys, and there is a lot of studies, including some studies done at the Mayo Clinic, showing that living kidney donors, even 5 years, 6 years post-donation, their actually measured GFR continues to rise. For example, if you have a patient or a donor who had a pre-donation GFR of 90 ml per minute, and they donate a kidney, their GFR is not 45, it's actually higher, 60 ml per minute and higher at 1 year post-donation. And why living with one kidney can be a concern? As nephrologists, we know once we have a low GFR state, that's associated with continuation of loss of GFR over time. And we know that this happened in the general population. As we age also, we lose GFR, so this will apply to donors as well, right? And we know that any low GFR state is also associated with high mortality and development of end-stage kidney disease. So as I said, the reduced GFR state post-donation may raise the question whether it impacts the overall general health of the living kidney donor. Is there a direct impact, increasing cardiovascular mortality? There are pregnancy, adverse events that can happen as well. Preeclampsia is higher in patients who have CKD and women who have CKD, chronic kidney disease. Hypertension, when you have estimated GFR that's low or real GFR that's low, you have more hypertension. And there is also an indirect impact of low GFR state, post-donation. What happened to those who gain weight post-donation, become obese, and they put more stress on their one kidney? So let's visit mortality and cardiovascular disease and what's the available evidence. As you know, there are many studies comparing living kidney donors to the general population across the world, from US to Europe, Japan, and there was no increased risk of cardiovascular mortality in donors when you compare them to the general population. Those some studies from the US and Canada showing that also when you compare those living kidney donors to healthy population controls, those who are very healthy, there's no increased risk of cardiovascular mortality, and survival is same. That's another slide showing that. So a nice meta-analysis that has been done looking at 118,000 living kidney donor compared to healthy populations, compared to donors that did not donate a kidney, to healthy population, general population from all over the world. Actually, 5 of those studies were from South America that actually did not show an increase of all-cause mortality, cardiovascular disease, hypertension, or diabetes in donors when you compare them to non-donors. So that's good news. Let's talk about end-stage kidney disease risk in former living kidney donor. It's not secret. End-stage kidney disease has been reported in living kidney donors, but there's no increased risk when you compare to the general population. Until about 2013, when 2 studies actually appeared in the literature, one from Norway and Kidney International, the other one from a larger population from the United States, published in JAMA, and talked about increased risk of end-stage kidney disease in the donor. In the Norwegian paper, they described about 11-fold higher risk of end-stage kidney disease in donors. They actually have a control group of healthy people that they described. Same thing applied to the USA, where donors were found to have about 0.9% lifetime absolute risk of end-stage kidney disease when you compare them to healthy controls. It's less, about 0.14%. and still lower than the general population, but was higher than when you compare them to healthy controls. What they found as well, that biologically related donors had higher end-stage kidney disease, so those who have first-degree relatives, for example, someone donating to their father or vice versa, parents to offspring, those are a higher risk if they're donating to immediate first-degree relative. Now, those two studies were really subjected to a lot of critique. They had very major limitations. The Norwegian study, for example, looked at very healthy population from the capital Oslo of Norway, and those are very well known to have better access to healthcare. They're actually more educated, and the donor population actually, cohort that were studied, came from all over the country of Norway. So the control groups, they really looked at very healthy, healthier than the donors themselves. There are so many confounding factors, limited follow-up. In the US study, the average follow-up was about, or median follow-up was about 16 years, so it's not enough to study occurrence of end-stage kidney disease. But the key point in the two studies that raised concern is that most of the end-stage kidney disease that have been reported in donors had occurs in donors who are related, biologically related to the recipients, especially if they're first-degree relative to the recipients. And that has been actually also found in a large meta-analysis looking at more than around 120,000 donors, and there was also more higher risk in biologically related donors for end-stage kidney disease. And the reason is, as we were talking about, in the past we did not have genetic testing. There are a lot of genetic diseases that have been missed. Now we know better, and we do better when we work up living kidney donors. So let's look at other non-end-stage kidney disease donor risk and the emerging challenges. I'm sure, like any, like in the US, you see in your clinic more and more complex patients, metabolically challenging patients, obese patients, and that's applied to the society. So I've been practicing kidney transplantation for 20 plus years, and I can tell you that the living kidney donor population has really changed and shifted over the years, where we see more older donors and donors with actually obesity and other risk factors. So let's visit what's the evidence tell us in those patients. So we'll talk about obesity and living kidney donation. As you can see, this is, we call it the RELIVE study. It's actually a consortium between Mayo Clinic in Minnesota, University of Minnesota, and University of Alabama, looking about 9,000 donors between 1963 and 2007, large cohort. As you can see that obesity rate increased from 8% to 25%, and that's actually just till 2007. We know now we have more and more obesity. So if you extrapolate those graphs, I think you see more living kidney donors coming to your clinic to be evaluated with obesity. And this has been looked at in a large cohort in the US. When you compare obese donors to non-obese donors, they have about two-fold increased risk for end-stage kidney disease, and we're talking BMI of greater than 30 in obese donors. So there is some hinting that obesity increased the risk of end-stage kidney disease, but actually it remains really, the absolute risk remain really low. We looked at the cohort of 950 donors, and those who actually lost weight to become donors, or those who started with obesity. Luckily, we did not find high risk for end-stage kidney disease in those donors, or higher risk of lower estimated GFR after donation. But we actually observed that there is more hypertension and diabetes happening in those who are either obese at the time they donated, meaning BMI higher than 30, or those who actually became obese post-donation. As you can see here, over time, we have some patients, we had more than 40 years of follow-up in donors, how the delta BMI increased over the years, can be plus, 4 or 3. That's actually major increase in BMI. This is a study published in JASN a few years ago, looking at from the RELIVE study that I talked to you about, that cohort. The good news in this study, it was negative. There was no increased risk of end-stage kidney disease in donors, but obesity actually increased the risk of having diabetes, hypertension, and proteinuria post-donation. Let's talk about hypertensive donor outcomes. Mayo Clinic in Minnesota was the first center in the world actually to start accepting hypertensive donors. And back in 2004, they established the first paper actually looking at donor outcomes after 1 year of accepting living kidney donors with high blood pressure. And that generated a lot of critique in the transplant community. How I was back then a fellow in training, how Mayo Clinic accepts hypertensive donors. I have to admit that most of the donors that we see at the Mayo Clinic in Rochester are white Caucasian donors, so this may not apply to more diverse population and those who may have actually more severe hypertension, such as those who have Hispanic background or African background. This is from the RELIVE study looking at whether mortality or renal outcomes increase in hypertensive donors. If you apply the newer definition of hypertension, there was no increase in end-stage kidney disease or mortality in hypertensive donors when you compare them to normotensive donors. We looked at our patients, our donors cohort. This is actually about 950 living kidney donors. And then at Mayo, when we see donors in the clinic, we actually get a 24-hour ambulatory blood pressure monitor. So what we did, we went back on all those 950 donors and we recategorized their high blood pressure, hypertension, based on the ACC, American College of Cardiology, American Heart Association 2017 hypertension definition. That's actually the same definition still applying now with a newer guideline that came about two weeks ago. And what we found out that none of the hypertension definition, because the threshold to call hypertension was lowered in the new guidelines in 2017, none of them have really predicted or was associated with lower GFR after donation. So in very highly selected living kidney donors with hypertension, I'll show you the protocol we have, there was no increased risk with lower kidney function post-donation. This is our Mayo Clinic protocol over the years. When it started in 2004, we used to accept living kidney donors older than 50 and older. Over the years, when we started to be more familiar and more aggressive in accepting hypertensive donors, actually we lowered the age to 40 or older. If they're African American, the age actually is increased to 45 years because the equal they play in those potential donors of African American, of African ancestry. So we accept those with stage 1 and stage 2 hypertension. If they're older than 40, no microalbuminuria, that applies to all donors. If they're treated with the high blood pressure, it has to be very well controlled, and we do an ambulatory blood pressure monitor on those. On one medication and a diuretic or maximum 2 medications. And of course, they should not have any end organ damage. For example, we do echoes on those patients to make sure they don't have left ventricular hypertrophy, and they should not have any end organ damage history, such as history of stroke or any other issues related to hypertension. Let's switch to women planning future pregnancies. This is from the University of Minnesota, where they observed that living women at childbearing age who become pregnant post-donation have higher risk for gestational diabetes, gestational hypertension, proteinuria, and preeclampsia. And that has been seen as well in Canada in a larger cohort of donors, that there is actually a higher risk, mostly found in nulliparous women, those who did not have children before donation. Those who had multiparous, who had prior children, had lower risk of preeclampsia. And that has been seen in the larger cohort. Showed you this study. It's a meta-analysis showing that preeclampsia is actually at twofold increased in donors compared to non-donors. So what do we do when we see a patient coming to be a potential donor at childbearing age? We advise them that there is risk. We tell them the risk is very low. It's not prohibitive, but we let them decide whether they want to pursue donation or maybe wait, have their family, complete their family, and donate later. And those pregnancies after donation should be considered high-risk pregnancies with blood pressure check. Now, other potential attributable risk to donation, I did not show you the data on kidney stones. We studied those in highly selected individual with kidney stones. If they donate a kidney, they do well. There was no increase of acute kidney injury or acute need for dialysis in donors when they get hospitalized. In conclusion, of course, living kidney donation is not without risks, and that's what we discuss with our individual who come volunteering to be living kidney donors. So we really want to have them follow up post-donation. We advise them on avoiding weight gain and have a close follow-up. However, for most donors, unfortunately, this is mostly applied to white donors. From the US, the absolute lifelong risk of end-stage kidney disease is less than 1%. So it's not actually high. Very important to exercise caution in first-degree relatives. Now with genetic testing and such, when we suspect that the recipient may have genetic disease, we actually test the donor for the same mutation of the recipient. And in obese donors, still there is some risk there that they're taking. And women donors at higher risk for eclampsia, preeclampsia about 2 times. And I hope I convinced you that recent studies addressing selected medically complex living kidney donors are reassuring. And to date, really, there's nothing in the literature, including our experience, that any of the risks that donors are taking are really attributed to living kidney donation per se. And I really thank you so much.
Bueno, tenemos espacio para 2 preguntas, así que por favor, este es el momento si desean hacer alguna pregunta. ¿Perdón? No, ya se fue el doctor. Allá tenemos una pregunta, allá atrás. Adelante.
Esta es una pregunta para el doctor Pinto. Estudios de genética se han convertido en la herramienta primordial de nosotros en la consulta. En mi consulta diaria ordeno Natera en alrededor de 50% de los pacientes. Cuando tenemos una variante positiva para enfermedad, pues lo entendemos de alguna manera y lo comunicamos con el paciente. Cuando, por ejemplo, en el panel de Natera nos sale genes de variante desconocida, que normalmente es la lista más grande, ¿cómo lo maneja usted como genetista o qué consejos nos da para manejar estas situaciones con los pacientes? Porque ellos, si ven 1 positivo y 10 de variabilidad desconocida, se preocupan más por los 10 que por el positivo.
Perfecto. So I will speak in English, okay? But I think that the question was, we are doing more genetic testing. We are seeing these reports with a list of variants, like 20 variants. Sometimes there is one that's positive there, but then how we deal with talking to patients about all these variants. That was the main message. The variants, yes. So usually the reports, let me take a step back here. Depending on the lab that you're using, there are some labs that they choose to report everything. So if a variant is rare and we have no other information, they're going to put in this list of 20 variants, they're going to call a variant of uncertain significance just because the variant is rare. Okay? There are other labs that they choose to not report single variants in recessive genes. So that's what I was telling you. It's always about the comfort that you have with the results and with the lab that you are partnering with. That's the first thing. So at Mayo, there are some colleagues that they choose to use these target panels with 300 genes, and then when you do a target panel with 300 genes, usually the lab will report everything because they don't care about the phenotype. Because if you're doing a target panel, in theory, you are interested in whatever is included in the target panel. So we see way less variants when we do exome sequencing or genome sequencing, because then the analysis is focused on exactly the phenotype that we're looking for. So if you say kidney cysts, even if there are 30 variants or 20 or 50 variants that are rare, but they are in genes that don't cause kidney cysts, the lab is not going to report. So that's the first thing. When we talk with patients, I don't expect our colleagues in nephrology to understand every single variant in every single gene. So that's why we have this multidisciplinary team. So we review together all these variants, and if we feel as a team that that variant doesn't meet reporting criteria, we're going to talk to the family and say, forget about it, it's an uncertain significance, but we have really low evidence that this could, in theory, cause disease. But again, you need a bigger team to deal with it. I completely agree with you, and I understand that's a problem when we see so many variants.
Muchas gracias. Allá atrás teníamos una pregunta.
Gracias. Quisiera preguntar qué recomendación o qué abordaje están haciendo en pacientes con lupus que tienen opción de donante vivo relacionado, si están haciendo estudio genético o tamizaje genético previo al trasplante.
Gracias. So the question is if we do genetic testing for patients with lupus. Yeah. So the problem with lupus is that there is not a monogenic cause for lupus. There are many GWAS studies, so these genome-wide studies. So we usually find these common variants that are more prevalent in patients with lupus in comparison to controls. Genetic testing done in a clinical lab, they usually don't report those variants because they are very common in the population. So we don't do germline testing for lupus nephritis, but there are some genetic studies on the research side trying to find some variants that would predispose to lupus, yes.
La última pregunta.
¿Sí? Ya, buenas tardes. Bueno, siguiendo con la pregunta anterior, en caso de pacientes con glomerulonefritis membranosa que haya salido que es una causa primaria con antiplá negativo y siga en actividad y no haya respondido al esquema tradicional y al alternativo, para el caso de hacer trasplante renal, ¿qué posibilidades hay de que el nuevo trasplante o el trasplante recaiga en la enfermedad original?
Lo que pasa es que esa pregunta tal vez es más para el doctor que habló de membranosa, justamente, porque él es genetista y él está especializado en trasplante de donante vivo. Bueno, sin más, agradecemos la presencia de todos ustedes. Gracias, doctores. Gracias a la Clínica Mayo por esta fantástica contribución. Gracias.